Thank you so much for having me today and to share updates. This is something that I've been sort of learning with you in the community, and we are developing this together as we go. And so I welcome your feedback. I don't know if I will use all this time today, so please talk to me now and over the course of the next 2 days and in the future. So I'll just start off by saying I have disclosures because I have a neurogenetics clinic and that there are people interested in treating these disorders, which I think is pretty awesome. So I wanted to take time to acknowledge that. Okay, so last year I actually presented this slide where, my amazing PowerPoint skills of making this line and putting things along the path to the end, but, kind of focusing on you need to diagnose someone with ALSP, and then there's a series of things that need to happen before you can have a disease-modifying therapy. And I graded it last year saying that we had some successes and things along the way, and we were definitely missing the disease-modifying therapy, improving quality of life, and we have to work on all the pieces of the path to get there. So today, we're going to talk about the natural history studies, and the goal of this is to define clinical endpoints so that we can measure whether these potential interventions work. Okay, so I'm going to just set the stage of what is a natural history study, and I'm going to use some slides that were developed by my colleagues at the Global Leukodystrophy Initiative, which is this enormous network of people that are working on this for the purpose of inherited white matter disorders or leukodystrophies. So we need them because we need to define the right goals of clinical trials. We need to define who will benefit most from the treatments and when you intervene. And we need to capture this information prior to diagnosis if possible. So Dr. Dang made this cute schematic for another disorder. And so I wanted to use it to kind of put into context that this is an effort that's being done in parallel for many different disorders. And we can kind of harness those efforts to apply here. We don't have to start from scratch, actually. And what we need to do is you need to have the access to the people who are living with the disorder, or ALSP in our case. We need to know what it looks like. We need to have all of the biomarker studies developed so that we can follow markers over time. And we need to have the preclinical studies, meaning like the models in the dish or in animal models to tell us why this is happening. And then with this information, you can have clinical trials that lead to FDA-approved treatments, which was the goal of the FDA listening session that you just heard from. And even better, if we can get this detection as early as possible, right? So you can just prevent all of this from happening in the first place. So the challenges to doing all these things, and is there a weird background sound? Maybe I need to move this. Is that better? Okay. We'll try this. The challenges are that ALSP is rare, right? There's just not that many people that have it. So I have this experience in talking to people. I have the same experience of talking to other providers who say, I'm not an expert in this. I don't know what to do. I haven't heard of this before. And I know that people who are diagnosed with this hear of it. So how do you get access to the clinical trials that are happening? We need to understand the full range of a phenotype. What does the disease look like in everyone who has this? And then how do you know which outcome measures are going to work? You have to validate them. And you have to have outcomes that the community tells you is important to them. Okay, so why do we need an ongoing natural history study? To design a clinical trial, of which we are lucky to already have some already in place, but we need to keep going because there's many potential ways to intervene. So to do the things that we need to know are how many people have a pathogenic variant in CSF1R, right? How many? Maybe I should use one of the hand things. That kind of sounds bad. Yeah. If you can't hear me, we have a problem. You're right. You're right in front of me.
I can't hear.
How about now? All right. Okay. So we need to know how many people have a pathogenic variant in CSF1R and how to define that. How many people who have the pathogenic variant will develop symptoms, and when do they develop symptoms, and is that the same in everyone? which symptoms, which imaging findings, and which biomarkers change over time that can be used to measure treatment efficacy? Can we prevent new brain lesions? Can we improve the MRI lesions? Can we prevent new symptoms? Can we resolve any acquired symptoms and make you go back to being healthy again? How long should a trial be done to determine the efficacy of a potential treatment? 1 year, 2 years, 5 years? We actually don't know the answer quite to that yet. How many patients need to be in the trial to demonstrate something works? And what is the range of phenotypes within one family, within one type of pathogenic variant that we've described? What should the inclusion criteria be for the future treatment trial? Somebody's age, the types of symptoms, the MRI findings, the lab findings, the specific gene variant, and what should the exclusion criteria be? Again, is that age? I have sort of grown up in neurology in the MS field, and there's an age limit. It's 18 to 55 for most of the treatment trials, where in reality, we treat people outside of that age range, but those are the main age range of people that we see. Should it be the length of the symptoms progression prior to being in the trial? The MRI findings again, or should you be excluded because you're pregnant, for example? So in order to build the infrastructure to do a natural history study, I work very closely with the Global Leukodystrophy Initiative, which is a National Institute of Health funded consortium, which all of you can look up. It just happens to be located right next door to where I work, so it's super convenient for me. But I'm going to share with you some slides from the GLIA CTN from Omar Sherbini, sort of the amazing manager of this effort. And so I'll just read it out loud. We are a consortium of institutions, clinicians, scientists, and patient advocacy leaders working together to promote advances in the diagnosis and treatment of leukodystrophies. So leukodystrophies, again, is inherited white matter disorders. Specifically, we seek to create a robust research infrastructure that will allow for collection, sharing, and analysis of standardized longitudinal natural history study data, development of novel clinical outcome assessments, and identification of surrogate biomarkers, ultimately paving the way for transformative therapeutic trials across the leukodystrophies. So it's perfect, right? That's what we want to do. In parallel, we will work closely with a diverse group of stakeholders to promote disease awareness and education, advocate for the adoption of newborn screening and early diagnostic programs, and establish clinical guidelines to support the short and long-term care of individuals living with these disorders. Okay. So I'm sharing this version of the GLIA CTN clinical research sites because when I started, Penn wasn't one of those, and I get to be included, so I like this line. I mention it that this is expanding. There are increasing number of centers that have expertise. And one of the advocacy wins that you've already heard about today is that the people that are part of the GLIA CTN expanded leukodystrophy diagnostic codes, where the G93.44 was included for ALSP. So this is a big deal to be able to not only give someone a diagnosis, but put that diagnostic code in the chart for all of the other things that go along with it that you need to do to take care of them. So they shared with me some current facts and figures. We've got 10 clinical centers. There's over 4,000 study participants enrolled. And this is from all over, essentially. And these individuals have helped researchers address some of the most pressing questions about how to diagnose and treat leukodystrophies. There are 40+ advocacy leaders, I believe someone's here. And we partner with dozens of advocacy organizations, including Sisters Hope Foundation, to promote education and awareness initiatives. And this is a long-running effort. So the 5 to 15 years is the duration of grant funding available through the National Center for Advancing Translational Sciences, which is part of the NIH. So there is investment in this effort in the US to keep this going. And I just want to highlight the advocacy committee strategic goals. I won't read everything here, but I want you to just highlight some really important efforts here because it aligns a lot with what you've heard from Sisters Hope, and this is bidirectional. And so they want to increase the quantity and quality of patient registries used by advocacy organizations currently participating. And they want to do it with the best practices approach so that we all are collecting high quality data that can be used and accessible and shared. And the second goal is to increase this communication and collaboration with the FDA. Okay, so I work within this Global Leukodystrophy Initiative, and they have a biobanking infrastructure. So everyone who comes to see me is offered participation in what they call the Myelin Disorders Biorepository Project. CHOP is the lead site, but this has been going on for decades. And basically, if you see me, I'm going to talk to you about it. But if you want to be enrolled, in addition to your clinical data, any blood samples, imaging, and any other type of testing can also be banked for future use. And the goal is to basically gain as much knowledge as possible about the person who's presenting in front of me and what diagnostic category they belong in. So I started this about 5 years ago. I'm trained in multiple sclerosis. I actually do basic science. Here is a very silly picture of me pretending to image on the 2-photon microscope. This is what I'm trained in, preclinical cellular biology studies. I get to work with the Bar-Or Lab in the Center for Neuroinflammation and Experimental Therapeutics, and I get to work with CHOP and the Global Leukodystrophy Initiative to start this neurogenetics clinic of undiagnosed white matter disorders, and then figure out what to do and how to collect biomarkers and establish natural history studies. And so just to give you an idea, so people started sending to me. This is something that I did one time a month and now more frequently because it turns out there's more people. And just so you can kind of see, when I stuck my flag down, a couple people found their way to me, but now I'm seeing quite a few people for diagnostic evaluation. And because of that, I'm collecting cohorts. So adrenoleukodystrophy is the most common one, so it's not surprising that I've seen the most of that. But ALSP is my second most frequent one, which you might not think for such a rare disorder, but and there's more people coming. And then I have a few other cohorts going. So people exist with these disorders that need to be diagnosed and taken care of with treatments. Okay. So this happened in the setting of the GLIA-CTN having their meeting in 2022, where they included ALSP for the first time. So we went through a series of efforts of inviting people who were clinically interested in ALSP and adult onset leukodystrophies and CSF1R and microglia biology, and gathered a group together. And so we discussed the challenges, successes, and needs to define the path to treating and curing ALSP. There will eventually be a publication on this effort. I'm not sure exactly when, but I do know that the next meeting is happening this year in September 2024, so we will certainly have lots of updates since 2022. But the successes that we discussed were that we had Sisters Hope Foundation, which is an incredible support, and you heard all of the accomplishments that have happened just in 2023. That we have industry partners to work with, that people that are interested in this disorder. There are many scientific challenges. Our models don't really tell us exactly what is happening in people. So it's very hard to know exactly what are all the steps that lead to someone developing symptoms. We're still working on that. And then, does having the pathogenic variant alone predict the disease course? So to answer these questions, we need improved awareness and access to genetic testing. We needed to develop diagnostic criteria. We need to agree on a name. I'm not going to talk about that today. That's its own thing. And we needed natural history studies. Okay, so this all happened at the same time that they had a pilot proposal, which I applied for to look at the phenotypic and functional characterization of ALSP. And so I was lucky to be awarded this and sort of invested in to start this effort. Defining what ALSP is and asking the question, can ALSP be identified prior to onset of inflammatory brain lesions, and can ongoing damage be halted or delayed? And so my hypothesis that I threw out there was there are peripheral blood biomarkers that can be identified early and before disease progression. These blood biomarkers could potentially be modifiable to delay progression. Okay, so this will be really cool if I can figure that out. But to answer this question, I need all the clinical data first to put it into context and to develop those assays. So that the pilot project is to develop the assays to answer this question. I won't talk about the assays today, but I'll say they're looking promising. It's a story for another day. But the goals are to establish the ongoing natural history study in collaboration with stakeholders from all over the world, and to develop these immunophenotyping tools that would be helpful potentially for diagnosis and following over time. And so to do this, we need input from key stakeholders, and that is first patients and caregivers. And so through Sisters Hope Foundation, we've actually had 2 forums inviting people to come talk to us. We'll keep doing that, take any input. Honestly, it's really important to know as our experience changes over time, what is important, what is burdensome, what are key features that we need to include, as well as the clinicians and the scientists. We need to have a retrospective study where we start from now and look backwards. And then a prospective study that includes ongoing in-person and telemedicine evaluations to incorporate that so that, that it decreases the burden of having to travel in person. And what we're working on is establishing templates for clinic visits that not only experts, but anybody could use who's taking care of people with ALSP, as well as assessments and tests for baseline and follow-up visits. And to establish standard operating procedures for key assays that could be done at centers of expertise, including the ones that I'm working on. Okay, so I actually introduced this at the United Leukodystrophy Foundation meeting in June of 2023, where if you want to be in the study, you just go to the Myelin Disorder Biorepository Project here, which you can just like Google. But if you go here and you find the Submit to Our Referral Survey, you start filling it out. You can say, I want to participate in a research study or be seen. That's up to you. And then you fill out the form and you say, I want to be in Dr. Orthmann's ALSP natural history study. That's the most explicit way to do this. But you can put whatever you want in that survey to be seen. And then once that's filled out, you're contacted by an MDPP team member to discuss research consent and any additional clinical opportunities if you're interested in doing that. Okay, and so since I've launched that, including the people that I've already seen, we have 30 people already within the whole consortium. So this is a huge number, actually, I think, that we've been able to collect. And it's from multiple sites. There are many people eligible for a prospective study. And even just having the clinical data of the genetic testing, the diagnosis has already been confirmed by the genomics core. So we're actually able to extract and interpret a lot of data, even from never being seen, just by what's faxed over kind of thing and de-identified. Okay, so a retrospective study. So that is, because I need a picture to understand anything, you enroll, you sign up, you call, you fill out the research consent, we go backwards. Okay, so you basically submit all your prior clinical data, clinical visits, MRIs, reports, images, or of a family member, the lab testing and genetic testing. It's de-identified, meaning you take away all your personal information. And then the magic happens, that's in the infrastructure. So this is a complicated diagram that was presented at ULF for Palazius-Merzbacher disease, a well-studied leukodystrophy, often with onset in kids. And I just want to focus on a few things, and then I'm going to show you a more appealing picture version of this. But basically, once you're enrolled, you get a study ID, the records are collected, the diagnosis is confirmed, and then you start to make these case report forms. And the case report forms are basically the database with all the questions that are determined by what we as the community think are important to collect over time and what is known about ALSP. And then once we start to collect that, then you can go back and start to analyze the data, especially once you have a cohort of people. This is for people that are within the consortium. If you're the goal is to have the ability to do this at any center. That's a future goal. But here's the picture version of this. It's easier to remember if you're visual like me, and also thank you to Dr. Adang for making this. So we get the records collections, we confirm the diagnosis, we develop these case report forms, we have this database that's actually accessible to and de-identified, so you're not getting anyone's personal information, but then you can analyze the data and submit for this data, basically shareable. And you develop standard operating procedures for how to analyze this data. So you get real world data and you can extract it, and then you can test whether does this known score of motor function, can you score all of these clinic records for individual study patients over time and understand the course of their disease based on this score. You can just do it with all the data you've already collected, and then you can verify it with other centers. And so that's basically what this little figure is telling us that rater 1 will go through everything for a scale. I'm doing this now for Palazius-Merzbacher disease to see if a scale that's used in another leukodystrophy can be applied. And there's rater 1, I'm rater 2. Sometimes we disagree, we discuss why, we adjust the scale, and then we go back again to see if that works. And after this is adjudicated, then we have a score that people can apply and even do during their clinic visits in the future, because we've said this is actually helpful in telling us about the course of disease, or it could be used in a clinical trial. And then once you have a cohort of people, then you can do the prospective natural history study, where you apply these, some of these scales going forward. Every time you see them, either by a research visit or a clinic visit, you can collect biomarkers like blood or other tissues, and then that is always documented into this ongoing database. And so, as you can see, now that's going forward. That can involve in-person and research telemedicine visits. We can perform standard scales that already exist, like we use in MS and Parkinson's disease and frontotemporal dementia, but it has to be based on input. What are people actually willing to do in clinic on both sides, right? And then we want to use standardized patient-reported outcome measures, like including the Neuro Quality of Life Survey, but there's also many more. And this is, again, based on what people think is reasonable to do and is helpful, and which has the questions that actually tell us all the things that, say, are shared in the FDA listening session, but not in the clinic. And then we collect and process the biobank samples. That can be immune cells, DNA, RNA, blood plasma, could be spinal fluid, skin biopsy, or other biopsies and autopsy material. So we have a prospective observational study ongoing. Sorry I made it so little. I just want to note that it's different than the study that I'm talking about. This is the Vigil-sponsored study. You can find it on clinicaltrials.gov. There's multiple sites, of which we are one. There's inclusion and exclusion criteria, and we will gain significant information from this study. And I'm really excited about it, and it's taught the community about how to do this and how to push things forward. But it's one aspect of it, and we have to actually keep this growing infrastructure of this happening. So one of the other things that we're working on for the prospective and clinical care is a standardized electronic health record template. So one of the things that you want to make sure people ask during their visits is this time to event data. So this is how we know how things change over time. So how old is someone with the first symptom? How old are they at the onset of each symptom, or the first imaging finding, or the changes in the imaging finding, or a time of diagnosis or time of diagnostic testing? With this type of data, you can measure that we were not good at this then and we got better at it, hopefully, going forward. But in addition to that, based on the discussions that the work group had, there's actually many more questions that we need to ask. And if you're ever with me in clinic, you'll see that they go on very long because I keep asking more questions. But really, we don't know whether any of these features have an effect on initiating symptoms or modifying them. So these are shareable. I'm putting them here as ideas, and I'm happy to share with anybody, but also take some away and add some in. But you can see there's head injury, history of infection that required hospitalization, headaches, migraines, bone abnormalities. Has anybody received treatments like bone marrow transplant or steroids? What neurologic symptoms do you have? For those of us who are trained in neurology in subspecialties, we tend to ask questions that apply to the specific type of people that we see, but that doesn't apply in genetic disorders, and we have to make sure to remember to ask all the other features that can show up. And then kind of think systemically, is your skin affected or any other organ system? On physical exam, the goal is to collect as many features that we can keep track of that change over time. So I'm just showing here that EDSS and timed 25-foot walk are something that we do regularly in the MS clinic, and it's really easy for me to do, so I can do that in a clinic visit. But you have to think about it, as well as a MoCA as it's not a great scale, but it is a scale that can be done and not take that much time. But we have to think about very carefully which ones should be there and which questions, or make the new scales that are more relevant, that are not burdensome. It's really important to note, is somebody using an aid to help them walk? And what does their walk look like? And which features do they have? The Parkinsonian features or the more MS-like features, that sort of thing. And then what sort of testing? And so what you might see as building here is that it shouldn't be a quick discussion, you have a diagnosis, see a visit. There's actually a lot of things that we should be talking about and doing. There's blood testing we can follow. There's other biomarkers like measuring retinal nerve fiber layer thickness. We need to get the genetic testing. We can look at immune cell biology within lab testing and follow it over time and follow how brain MRI changes. And so you might notice that I'm kind of going back and forth between the clinic and research. I think they sort of go together when you have a disorder that doesn't have a treatment, right? So we're learning as we go. But the goals for this study are that every person's experience is important, that the de-identified data acquired will be shareable with the international community. It will enable collaboration with researchers and industry, and that it will generate outcome measures for clinical trials. And that we will be able to expand our clinical experience and knowledge to answer those questions that come to us in clinic about prognosis and treatments that we can't yet answer. Okay, so who's eligible? So these are not too strict, but anyone with a pathogenic or likely pathogenic variant in CSF1R, anyone with variants of unknown significance in CSF1R with clinical symptoms that could be consistent, a family member of someone diagnosed with it, a family member who's passed away from ALSP. And because this is within the context of the GLIA-CTN, you actually can be part of this biobanking effort even without exactly being part of the ALSP study, or maybe you could be as we learn about these more rare variants that cause a similar set of symptoms. So it's the advantage of working within this larger consortium. And I just want to mention there's also a Canadian registry that is being run by Roberto Lapiana here, and I believe has made significant strides, so you should ask her about it, and is getting presented at upcoming conferences. And this is definitely an effort that involves multiple centers so that we're all gathering as much information as possible. And so with that, I will stop from there and thank everyone in the community and the organizers of this conference for the opportunity to talk about it. I'm happy to take any questions.
Can Canadians participate in any of your American studies? I know like the natural history ones, but like say for example, your PhD.
Yeah, so I think like anybody can fill out the website and submit data. And if anybody applies through Dr. Lapiana's registry, we're collaborating anyway. So in effect, the hope is that this is data that you don't have to share over and over again, but rather as a collaborative effort. And recognizing that it's asking a lot of people to participate in so many different versions of trials. So we have a prospective trial happening. This was something that we'll build the infrastructure for to keep things going over time.
Any other questions? Quick question. How far away are you from, is a great leader in terms of electronic health record integration research. How far away are we from case finding through big data searches of large health systems?
So I am not there yet, but there are a lot of people working on that. That's an amazing question. I think the more I'm part of this community, I'm really understanding how much that is needed. There's so many different places that have different types of electronic health records that sort of limit, like, I can make an Epic Smart Set to share with everybody that's doing it, but that doesn't apply to the other health record systems. So it requires some flexibility to figure out what works best at each place. But once we collect that data and extract it into a database, then it's all sort of normalized again that we can use it. But for the big data, if we work with stakeholders like Epic or some to find, what are the features in the record we could have looked for, or the big biobanks or something to see what's available in there, that would be a way to, that would be an amazing way to collect more data that's actually just sitting out there waiting to be found. I wish I knew more about it.
Would such searches include patients who were previously diagnosed with other names like HDLS? So for instance, I think of all the HDLS patients that we see before the gene was discovered, especially with the retrospective It'd
Mhm.
be so interesting to figure out a way to make sure that we can access those numbers as well.
Right. I think that's a really good idea and an important effort for anybody that's interested in, say, collaborating on collecting these retrospective data, even finding ways to search through the record, right? Because we don't have the ALSP diagnostic code, so it would have to be by symptoms. It would have to be by autopsy findings if it's in there. I think there's a CSF1R monoallelic code that I was using. Or leukoencephalopathy. So it will take some creativity to actually pull everything out for the possibilities.
What do you see as the future role of biomarkers? How do you think those would be used in the future?
Yeah, so one of the things that I would love to be able to do, because I get a lot of questions about this, is does this person have ALSP? They've had genetic testing, they get a report of a variant of uncertain significance, and they have some of the clinical features, but maybe not all of them. And so this is, maybe the ideal situation for a diagnosis where someone, if we had a treatment, could intervene right then, right? And prevent anything else from happening. But we're not quite there yet for knowing that. And so the first pass would be to say, because we have this biomarker assay to say this is pathogenic, they have the disorder. That would be an amazing use of it. Another one would be this is a biomarker that reflects ongoing damage, right? There's a lot of biomarkers out there that are useful for that, like neurofilament and GFAP, that people are using in other disorders. And we don't yet know how it applies here, and it's something we need to look for. And are those changed with interventions? Is that one of the outcome measures that says, like, actually we've prevented further damage from happening? It could also be an imaging biomarker. OCT can be used to show thinning over time. If you can stop that thinning, that means perhaps you're preventing loss of neurons, and So I think they will go together as a package. I don't know which one will be more important in this case, and that's where we sort of have to collect the data to answer that question and get funding to do the tests.
One of the challenges here is going to be around harmonization of
Mm-hmm.
think of these different pilot studies or smaller studies. Have you started to contemplate what those might look like? Have you started to think about standardized SOPs?
I think that was one of the things I was told to talk to you about, actually. So thank you for bringing that up. But yeah, so I'm sort of thinking on the smaller scale right now as I'm simultaneously learning how to do this and create the infrastructure to even just for the blood assays. Like, can someone collect blood at another site, send it to me so that we can just run it the next day? Like, what is the standard operating procedure? What is the kit they need to have to do that? How in advance do they need to contact us to make, things like that, which seem simple but are absolutely not in the clinical world, to make sure that it's done correctly and coordinated. So that's sort of where I'm starting from, just like the basics. Yeah, thank you.
You have questions? My question is, the information that we're learning here today and your presentation, how is that available to someone who has a patient, a family member that's sick and they're searching? Because I myself found out about clinical bone marrow transplants through looking through YouTube and looking through people giving presentations and doctors and studies like that, and thinking maybe this, just looking, for straws. And so, like, if people that don't know anything, like the way, we hadn't had that many family members yet, we were still in the dark, how can we give them where they can hear what we're hearing today, and also so they'll know how to do genetic testing and all of those things? Because unless you're even thinking about looking at the brain or the matter or anything like that, what do you do next? And a lot of times it's up to us to advocate for our own family members. So how do we educate ourselves? So I'm just asking, like, where will this information be available so that we can be able for awareness and to share?
So
Because we learned a lot today, and hearing everybody there was the stories that when we were in the dark, not knowing, and, feeling it again, that's exactly how the different levels of it, right? And the families and the loss and everything. So when we can help others with sharing this information is important. And thank you guys for inviting us back again, because it is helpful to our patients and the caregivers and those of us that we're still learning too. Thank you.
Thank you for raising that incredibly important point. I mean, I think Erin and Heidi have mentioned that one of the goals for this coming year and for last year is to get education out there. People need to understand that first you need to diagnose it, and how do you do it? And second, what do you do about it? And so we're in an all takers mode. All options are available. So first, everything is accessible and will be accessible through Sisters Hope. This is, an ongoing presentation, honestly, that I've done is, it's on YouTube from United Leukodystrophy Foundation last year. We've advanced a bit since then, so we'll keep going and kind of sharing, but happy to take any ideas for how to broadly share this information, because, it's all the stakeholders that need to know, right? The people who are diagnosing or potentially diagnosing, and the people who are affected.
I believe you also briefly mentioned retinal nerve sheath fiber.
The retinal nerve fiber layer thickness, it's a OCT.
Yeah.
It's basically like a little infrared pulse that you look at a dot and it measures, it's like an image biopsy of your retina that it's super easy and doesn't hurt. So it's kind of my favorite type of test.
Has anyone looked at that in ALSP before?
Well, I'm collecting it and happy to encourage anyone else to do it, and then we will see if that is helpful.
Okay. Is anything known about symptoms in the eye, or do patients experience any changes in ocular health or anything over the course of their disease?
This is an amazing question, and it looks like I need to add it to my list. I mean, typically we ask about vision, and so I think within the variety of what's been reported, yes. Whether how it's specific to particular people or changes over time, I don't think we quite know yet.
Okay, awesome.
We can take one more question.
Jen, I think I should know it because we are collaborating on this, but right now I don't remember. Are you keeping track of the misdiagnosis done in patients? Because I think that would be great to have a breakdown of how misdiagnoses were done, so we can then reach out to clinics in a targeted way.
Yeah, I think that's a good idea to have that as part of the
We are
key
not doing
list.
that yet, right?
I mean, so in the retrospective, we're sort of with whatever we find, but I think we should be collecting that. So,
Okay.
yeah.